Alrighty, guys. So we're going to be talking about our services, the services that we provide, and also the specialties, what we specialize in. So these are two different things because the services that we provide are like physical therapy, occupational therapy, and the specialties, what we specialize in, is treating multiple sclerosis or cerebral palsy. So we're going to get into all of that and talk a little bit about what each one of those disabilities are and give you a little bit of background history so that you're not totally in the blue for the front desk receptionist to answer the phone or something like that. So to tell you a little bit about TheraFit, though, we started out in the basement of my mom's house, Gina, and this is the house that we started in, and it was 500 square feet, and we only offered fitness therapy. So a fitness therapist is some personal trainer that's certified to be able to work with people with disabilities, and this is where we offered it. And it wasn't until 2012 that we ended up getting our new location in Westminster. So this is, again, another photo of what it looked like inside of the house. So just some cool history of where we started to where we are today. And this was the first location that we moved into. It was 1,800 square feet in the middle of downtown Westminster, and it's just cool to see. We started in 2009, and actually December of 2006, and by 2012 we finally moved into that location. Now you can see now we're in 2017, and we have 3 locations and a hybrid location. So we're just really rapidly growing since 2012. So now getting into the services and whatnot, when we talk about our mission, our overall goal, again, we're always about adding value to someone's life. So when they ask what we do, we help people who've been affected by neurological disabilities, more specifically multiple sclerosis or Parkinson's or something like that, become more active, mobile, and independent. And those are the 3 things that we really feel like we do when we're treating our patients. We specialize in getting them more active, independent, and mobile. And these are the things that we talk about when we're meeting our patients, is how can we get them more active, independent, and mobile. So first, we're going to talk about our services, like I said. So I really want to give you guys the mission, kind of some history, just to let you know where we're coming from. And then we'll start talking about the services that we offer. So the first service that we offer is going to be physical therapy. And this is covered through insurance, and covered through most insurance companies. And what we end up doing is when someone asks, to verify insurance or something like that, we usually just give it to our billing department and allow them to make all the calls and see if we accept their insurance or if we don't. But for the most part, we do accept all the major insurance companies, including Medicare and Medicaid, and physical therapy is covered through it. So with physical therapy, we have goals that we're working towards. So we always have a goal, some kind of functional goal that we're trying to work towards to better the patient's life. So it's got to be functional, meaning that it has to benefit their function, their quality of life. So like we're working on a goal like getting them up from standing, going from sitting to standing, or getting them reaching outside of their base of support to keep them safe and secure from falls. So physical therapy, we kind of think of physical therapy as the lower half of the body, and occupational therapy, which is the next service that we offer, is like the upper part of the body. But in our practice, it's really not like that. Like traditional outpatient therapy clinics, you'd see, the occupational therapist would be treating the hand, the physical therapist would be treating the knee, the foot, the hip. In our practice, what that looks like is when we're talking about treating people with neurological conditions, physical therapy usually works on gait. So walking is gait, and that's what we classify as gait. So how they walk, getting them up into walking, weight shifting, balance. We're working on getting from sitting to standing. We're working on taking steps with, in a gait trainer, and then in a walker, and then with a cane, and then without any cane. We're trying to progress them to walk independently. Our goals are always to get the person as independent as possible. So physical therapy is usually going to be working on gait, balance, and that kind of thing. Sometimes we're looking at pain with physical therapy as well. So we get like lots of back pain patients, hip pain, knee pain, that kind of a thing. Some of those orthopedic patients we're going to be treating more or less their pain. But occupational therapy is the next one that we're going to be talking about. And that's really geared towards a couple different things. So when we talk occupational therapy, we're looking at things like cooking, bathing, feeding, eating, not actually the swallowing component of eating, but like getting food together, preparing a meal, getting into and out of the cupboard, transferring into and out of the car or the shower. That's also can be a physical therapy goal too. So some of these kind of mix in between one another, but it's important that the occupational therapist and the physical therapists that are developing the plan of care for the patient are communicating and not working on that same goal. So that's the one thing that we need to watch out, is that we're kind of treating, making goals that are separate from the different disciplines. So another thing that we do in occupational therapy is getting people prepared for work or back to work. So we might be looking at managing tasks, like how to sequence something, for instance, like following, multiple step commands or something like that. So we're really looking at more or less like the skills that are required to be able to work, or finding skills for an individual to be able to work. So the next thing that we do in occupational therapy is also covered through most of the major insurance companies that we're credentialed through. So the next thing that's up is aquatic therapy. This is generally done in our physical therapy setting. So usually we get somebody into physical therapy and then start them. Now, if someone has just a script for aquatic therapy, we still usually set them up on land once a week, then in the pool once a week. We like to have that land visit to make sure that everything that we're doing in the pool is following through. If we're going to be seeing them 2 times a week in the pool, then we're at least trying to get them on land every now and then to be able to do the assessment and make sure that everything that we're doing is helping. So we still need to see them on land for the initial eval and the assessments. So we do aquatic therapy. We usually sublet that out to different locations, so the YMCA or the MAC or some kind of a fitness facility. And that works out very well because most of them have really nice accessible pools with changing rooms, and that's what we like to have for our patients. So the next thing we're talking about is fitness therapy. This is, again, what we started with. So this is truly the first thing that we started doing, and it was all based around, working with the patient in a fitness, sort of way to rehabilitate them. So that includes strengthening components, like really working with weights and stuff. And it's more of an activity-based therapy concept for physical therapists that are kind of oriented with activity-based therapy. But basically, it's not geared around, compensating for, if someone had a stroke and their left side's affected. It's not geared towards compensating for the affected side. It's geared towards strengthening that left side, getting it more active and independent. And that's kind of what our whole program is about. And it was founded off of the idea that fitness can help somebody with a disability become more functional. So, that was kind of the premise to which we started working with physical and occupational therapy as well. So the next thing that we're talking about is membership. So not all of our locations are going to offer all these. So you have to check with your supervisor to make sure that yours does. I'm just going over every service that we offer. So this is a full encompassing tutorial on how many different services we offer. Again, not all the locations will offer these. So, but the gym memberships are for the larger locations, and basically it's a continuum. So we usually charge like a flat fee of like $45 a month to be able to come in and use the equipment as a client would want. So this includes the quadriciser programs. So that quadriciser is not included in that flat rate fee of $45 per month, but we would charge additional fees to be able to use the quadricizer or really the MotoMed. Those are the two things that we would really be charging an additional fee per month to be able to utilize. So it ranges from $45 all the way up to $225 a month for the memberships. The next thing that we do is consulting and contracting. So we work with a lot of the local adult day facilities in trying to get rooms like you see on the screen put together. So we actually were consulted to be able to build a fitness room for all the clients at this particular adult day facility in La Plata, Maryland. So we helped develop the room to the colors, to the flooring, to the equipment that you see in it, some standards, the quadricizer, a solo lift. You can't see it, but there's also a up and go picture to the far left there that I guess you can see just a little bit of it. So, and also the very large mat table. So we put this room together, instructed a fitness therapist on how to run it, and created a program around it and helped people to be able to get the fitness that they needed. So the next thing that we do is durable medical equipment. So we are able to supply this through most insurance companies, and there's a separate tutorial on how this program works because it is quite it's quite hard to explain sometimes because some pieces of durable medical equipment are covered, some aren't, and the process in which to help somebody get some durable medical equipment can be quite tedious. So we covered that separately. So the first thing that we're going to be talking about in our specialties is multiple sclerosis. By far one of the things that we see the most of in our clinics. And we're going to be talking about a lot of the different types of multiple sclerosis. There's 4 different types of multiple sclerosis, the first of which is relapsing remitting. This is the most common form of multiple sclerosis. About 85% of people with multiple sclerosis are initially diagnosed with relapsing remitting. People with relapsing remitting have like temporary periods called relapses and flare-ups or exacerbations in which new symptoms appear. So they'll have an exacerbation, and within a few weeks, the result of the relapse might be they have no use of feeling in their legs, or their gait's just really bad or unsteady. And then they'll have this time where they remit. So they relapse, they go back, then they remit, and they start progressing forward again. So maybe that they go through 2 weeks where they relapse and they're not able to use their legs very well. And then the following month, they kind of regain control over their legs and they're able to walk better. They're almost as good as they were before. So that is the first type of multiple sclerosis. The second type that we have here is secondary progressive. A lot of times these are abbreviated by, so like relapsing remitting would be RRMS. Secondary progressive might be SPMS, primary progressive PPMS. So all of them are like they use their first initial, second of the first word, first initial of the second word, and then MS, multiple sclerosis at the end there. So anyway, secondary progressive and secondary progressive MS, symptoms worsen more steadily over time. So this is usually with or without the occurrence of a relapse or remission. So you might not have actual exacerbation that happens where kind of like in relapsing remitting, it might be one episode that sets the person back. This might just be over a very long period of time. It's like a very long episode, whereas the patient's just generally getting more and more weak. So people who are diagnosed with relapsing remitting MS usually transition into secondary progressive MS at some point in their life. So it could be 30 years. I've seen people go 35 years, with MS. Then they eventually transition into secondary progressive. So it's just as the disease begins to kind of evolve later in life, it gets a little bit more aggressive. So we see that primarily as people get older into their late 60s, kind of early 70s, we tend to see that a lot more. Secondary progressive, you would kind of expect just if you would imagine a chart and the chart had, their function on one side and then years on the other, you would just kind of expect to see like this slight downward curve. As the years extend, their function goes down. And that's traditionally what you would see in secondary progressive MS. The patients just over the years kind of getting worse and worse. However, we've had patients that do get better. So kind of like relapsing and remitting, where they go through these ups and downs, we actually have seen secondary progressive patients start walking better, get better balance or something like that, The reason I tend to think this happens more often than not, and this is just my clinical judgment from being able to see some of the patients over the years that we've treated them, is a lot of times someone will go from walking a whole lot. So they'll be walking with a walker, and then they'll have a couple of falls, and they'll get scared, and then they'll go to a wheelchair. So now all of a sudden they're walking, maybe 7,000 steps a day to primary relying on a wheelchair and not walking nearly as much, maybe 30 steps a day, as opposed to the 7,000 or the 5,000 they were walking before, So we've actually had patients that this happened to. They've walked into our clinic for years, and then all of a sudden they have a couple of falls and they get scared and they go to a wheelchair, and then they rapidly go downhill. And it's no wonder, because now they're primarily sedentary and sitting all the time. And studies have shown that more sedentary you are, the more problems arise, the weaker you get, et cetera, et cetera. So it's no wonder that, some of the patients that are coming to us for the first time, maybe they're a year into their wheelchair. A lot of them will say, I stopped walking about a year ago. And then all of a sudden they just see this huge increase. And it's because they were walking a year ago, so the strength is still there, the components are still there, but they just aren't walking anymore. They don't feel safe, they don't feel secure, their balance is poor. So once we start getting them up and really starting to strengthen up the muscles again and get them, that muscle memory comes back and they start really working again, then they slowly but surely begin to get more confident, more secure, and a little bit stronger. So that's where we generally see that huge bell curve, where they start coming to us about 3-4 months in, all of a sudden they have these huge goals that they're hitting. And, that's primarily the reason why. We've even seen primary progressive patients that's happened to, which is a good segue. So this is a type of MS that is not very common, and it's only occurring in about 10% of people with MS. So primary progressive is characterized by slowly worsening symptoms from the beginning, with no relapses or no remissions. And again, we have seen that before, so that people have gotten better. It's just very, or went through slow times where they've gotten a little bit better. But it's just usually people with primary progressive are in a little bit later of a stage of MS too. So progressive relapsing MS, this is the rarest form of MS, and it occurs in about 5% of people living with MS, and it's characterized by steady worsening of the worsening disease state from the beginning, with acute relapses but no remissions or without recovery. So this is, again, the last two are, obviously going to be the worst types of MS. So there's another one on here called that's not on here rather, called tumefactive MS, which is, again, another somewhat rare one. But multiple sclerosis typically affects the legs and then the arms. When you have tumefactive MS, it's usually a form of relapsing remitting, and it tends to be a really quick onset, and it presents a lot like a stroke. You get left-sided hemiparesis, or you get left side affected. So you'll get the left leg and the left arm is affected instead of just the legs or just the arms. So, but that's another one on there. That's not on there. It's called tumefactive MS. So we're going to be talking about a little bit of, so the top's cut off there a little bit, but the anatomy of language. So before we start talking about strokes, which is what we're going to talk about next, I'm going to give you guys a quick lesson here, and we're going to talk about aphasia. So aphasia is what we're talking about, what speech, someone's having difficulty or they cannot communicate in some way. So we have three different forms: global, receptive, and expressive. So you can see here that if you're looking at the middle, there's kind of right behind the word global and receptive, you see that little blue portion of the brain, and that's Wernicke's area. So that is the area that, so a lot of this is kind of cut off there, but you can see the receptive, the lesion. If there's lesion in that area, you're going to have receptive aphasia, meaning you can't understand what's being spoken. So maybe you can still express yourself, so you'd be able to talk, but you wouldn't be able to understand what's being spoken. So maybe you can understand it if you read it. Maybe you have trouble reading, but you can only hear what's coming in. So there's lots of different ways that this can present, but just that part of the brain, usually this is only going to happen on the left side also. So the left side of the brain is the part of the brain that controls speech. And if these two centers, so first being Wernicke's side, if that is affected, then you will have receptive aphasia. You will not be able to interpret some form of communication. And if the other side, Broca's area, that side that is listed in red right there, is affected, then you will have a hard time expressing yourself. If both places are affected, then you will have a hard time interpreting or expressing yourself. So you won't be able to interpret language as it comes in, and you won't be able to express language as it comes out. So that is a very quick rundown on aphasia. But next we're going to be talking about stroke. All right, so next we're going to be talking about stroke. So another word for stroke is cerebral vascular accident, or you might hear it as CVA. And typically we categorize it into right side affected, left side affected. Because typically it'll affect just one side of the body, because typical stroke just presents on one side of the brain. So stroke, another word for it is brain attack. So you'll hear it in a lot of different words for it, but it can happen to anyone at any time, and it occurs when the blood flow to an area of the brain is cut off. This happens when this happens, the brain cells are deprived of oxygen and they begin to die. And when the brain cells die during a stroke, the abilities controlled by that area of the brain, such as memory, muscle control, are lost. And once they are lost, it's very hard to get back. And because a lot of times those brain cells are just dying. So how a person is affected by their stroke depends on where the stroke occurs in the brain and how much of the brain is damaged. So for example, someone who had a small stroke might only have minor problems, such as like temporary weakness or difficulty moving an arm or a leg, whereas people have a larger stroke, maybe permanently paralyzed to one side of their body, or the loss of the ability to speak. Some people can recover completely from strokes, but more than 2/3 of the survivors have some kind of long-term disability from it. So you can see the majority of people that have strokes have some type of a large long-term disability for it. So that's why we see so many strokes at our facility. So just a couple of I guess not cool statistics, but some interesting statistics are that each year nearly 800,000 people experience a new or recurrent stroke. So a stroke happens every 40 seconds, and it's the 5th leading cause of death in the United States. Every 4 minutes, someone dies from a stroke, and 80% of strokes can be prevented. Stroke is the leading cause of disabilities in the U.S. So, and that on our blog you can check out. We did a recent article on stroke, and that 80% of strokes can be prevented. They've tied atrial fibrillation to be a leading cause of stroke, and of course atrial fibrillation is reversible. So if you want to go check that article out, it's a pretty cool article. So that stroke, a lot of times the aphasia is following a right side affected stroke. So many times over the phone when we intake somebody, we're asking about what is the presentation. If they say, maybe it's a caregiver talking about, oh, my husband's right side is really weak, then we probably know that person's going to have some kind of aphasia coming into us as well. So we'd want to write that down in the chart. So next we're going to be talking about traumatic brain injury. There are a lot of different types of traumatic brain injury. So we're going to go through each of them. Also, the abbreviation for traumatic brain injury is just simply TBI. So you might hear traumatic brain injury, head injury, TBI. You might hear ABI, which is an acquired brain injury, which we don't really get into in this list, but many times that's due from a loss of blood. So maybe someone's gotten shot a couple of times and they've lost a lot of blood to their the blood circulation isn't going. So then the brain starts to die off just due to a lack of blood supply. Sometimes it could be, for instance, someone overdoses on drugs. They're not alive for multiple minutes. The brain's deprived of oxygen, and then they have an acquired brain injury from it, and those can be very serious. So, but brain injuries, they tend to be classified as traumatic or non-traumatic, and it basically just describes the way that the injury was caused. So, traumatic brain injury, would be caused from a traumatic event, whereas a non-traumatic could be something like an acquired brain injury. So they're also classified as mild, moderate, and severe to indicate the initial severity of the injury. So other terms such as diffuse, penetrating, may be used to describe the type of injury. So the most commonly used terms are going to be the ones that we talk about. So first, we have diffuse axonal. Diffuse axonal injury can be caused from a shaking or a strong rotation of the head, as within shaken baby syndrome, or by rotational forces, such as a car accident. So the injury occurs because the unmoving brain lags behind the moving skull. So the brain's shaking inside, and the skull is maybe the brain's moving one way, the skull's moving the opposite way. And this causes the brain sutures or the brain structures to tear. So you get this tearing of all the brain tissue inside of your head, and the tearing of all those tissues is what's described as a diffuse axonal injury. So there's extensive tearing of the nerve tissue throughout the brain, and this can cause also the brain chemicals to be released, which cause additional injury. So the tearing of the nerve tissue disrupts the brain's regular communication and chemical processes. This disturbance in the brain can produce temporary or permanent widespread damage, coma, or even death. So a person with a diffuse axonal injury could present in a variety of functional impairments, depending on where the shearing occurs. So typically, someone with involved diffuse axonal head injury is going to be the most worst type of brain injury, because that's where the actual brain tissue has been really impacted. So whereas like a counter injury that we'll get into later is more or less due to the amount of swelling and stuff like that. With a diffuse axonal is an actual tearing of the brain tissue, so it's very hard to rehabilitate from. So the next one that we have is concussion / mild traumatic brain injury. That's what it is classified as. So you might see MTBI with a smaller lowercase m. But a concussion can be caused by direct blows to the head, shotgun wounds, violent shaking of the head, or a force from a whiplash type injury. So they're both closed and open head injuries can produce a concussion, and a concussion is the most common type of brain injury that we will see. A contusion is going to be another one that I don't have on here, but that we'll talk about under mild traumatic brain injury. A contusion is a bruise on the brain, or like bleeding on the brain caused by a force. It's like a blow or a jolt to the head. So the next one is definitely one that we see more of, and it's a Q-counter-Q injury. The Q-counter-Q injury describes contusions that are both at the end. They're both at the site of the impact and on the complete opposite side of the brain. So this occurs when when the force impacting the head is not only great enough to cause a contusion at the site of the impact, but then it is also able to move the brain and cause it to slam into the opposite side of the skull. So to give you guys kind of an idea of what would happen is if someone was skateboarding and they were about to jump off a flight of stairs, and or they do jump off a flight of stairs and they miss the landing and they're not wearing a helmet and they slam their head into the ground. So what happens is the skull is very hard, the brain is very soft. So as the skull hits the ground, the full impact of the brain, it's just like an egg. The yolk inside, the brain inside the skull is going to slam against the front of the skull. But then you have like this ricochet effect that after it slams into the front of the skull, you get like this whiplash effect where the brain then whips back and then hits the back side of the skull. So you get injury on the front side of the skull, but then also the back side of the skull. So the brain's now impacted two different sides, the front side and the back side. And that's where you get that global kind of impact on the brain there. So you're going to get a lot of trauma on the front of the brain, a lot of trauma on the back end of the brain. This can happen too without some kind of blunt force. So it can also just happen by getting into an accident. The head goes forward into the airbag. The brain comes forward really hard into the skull, the front of the skull. Then you whip back into the chair and hit your head against the seat cushion. But then the brain hits the backside of the skull. So you get this kind of just shaking of the brain inside of the skull that can do a lot of damage. So second impact syndrome. So this is going to be, and this is also termed as a recurrent traumatic brain injury. So you'll see second impact syndrome or recurrent traumatic brain injury. And it kind of speaks for itself on the second one. And it can occur when a person sustains a second traumatic brain injury before the symptoms of the first brain injury have healed. So the second injury may occur days or weeks following the first, and a loss of consciousness is not required. But the second impact is more likely to cause brain swelling and widespread damage. So this can often happen as someone's like falling after a brain injury. So they've had a traumatic brain injury, and then they've fallen again. So penetrating injury. So we're going up to the right-hand side, and that's pretty much speaks for itself. A penetrating injury to the brain occurs from the impact of a bullet, a knife, or other sharp object that forces hair, skin, bone, and fragments of the object into the brain. So then the brain is actually damaged from an exterior blow to it. Shaken baby syndrome. Shaken baby syndrome is a violent criminal act that causes a traumatic brain injury. So shaken baby syndrome occurs when the perpetrator aggressively shakes a baby or a young child, and the forces of a whiplash-like motion or cause the brain to be injured. So this is this can be a very widespread type of brain injury, and a lot of times because a lot of babies are so young, they have a lot better of a chance of recovery than somebody that was older and that would happen to, just because of all the neuro pathways that are being formed at such that young age. The younger, typically, the better chance of healing. Not all the way down to infancy, but a 4-month-old on one of our groups just recently suffered shaken baby syndrome and was intubated, whole 9 yards, 100% intubated, not breathing on her own. had a feeding tube in, everything, not functioning at all, 0% brain activity, and it's been a week and a half right now, and she's starting to eat again. So it's just a long process, and you don't know, how they're going to react or how they're going to heal. But because they're so small and just all those nerve pathways are being formed, they have a lot better of a chance of recovery. So, locked-in syndrome. This is a rare neurological condition in which a person cannot physically move any part of their body aside from their eyes. So they are inside of their body, but they're not able to actually move it. So they can move their eyes because the eyes work on a different type of nerve. They don't work through the spinal cord. They work from a nerve that comes directly off of the brain. So they have a little bit. So all those vital things like the heartbeat, everything else can be there. You're breathing, but the only volitional movement that someone with locked-in syndrome will have is through their eyes. So, and we have had a couple of people that have had locked-in syndrome. It's very rare, but we've had 2 patients that have locked-in syndrome. So, open head injury. An open head injury, also known as a penetrating head injury, is a head injury in which the dura mater is breached. So the outer layer of the meninges, that outside layer of the skull, is breached. And the penetrating injury can be caused by high velocity projectiles or lower velocity. So again, those knives, bullets, those types of things. But that is, I meant to put that right underneath of the penetrating injury because you also hear it said as an open head injury. And then the last thing there is the closed head injury, and the closed head injury is an injury to the brain that's caused by an outside force without penetration to the skull. So this is with a closed head injury. When the brain swells and it has no place to expand, this can increase the intracranial pressure, which is the pressure inside of the skull. So you get this like enormous amount of pressure in the head because the brain is swelling, but the skull doesn't expand. So there's nowhere for the swelling to go. And you get a lot of brain tissue that's impacted because of that, and it dies because of that. So closed head injuries a lot of times are those ones that the skateboarder scenario all over again. The skateboarder is going, they get that counter-cue injury, no place for the brain to expand, and a lot of times they'll end up having to cut out portions of the skull just to allow that brain to be able to expand and swell. So then they're going back in and putting those portions of the skull back into the brain. So, or back fixing their skull back to the other parts of the skull. So they're going in later and adding that skull back. So, next we're going to be talking about Parkinson's disease. So we are an LSVT big facility, which that means we treat Parkinson's through a specific program that our therapists have went through continuing education to receive. And the program works on incorporating very large, big ballistic movements to achieve smaller, more normal movements than someone with Parkinson's is able to get. So to tell you a little bit about Parkinson's disease, is a neurodegenerative disorder that affects predominantly the dopamine-producing neurons, and it's in a very specific place of the brain called the substantia nigra. So the symptoms generally develop over like many years. It's not really a quick onset, but it's like a long progressive onset, and the progression of the symptoms is often a bit different from one person to another. So you're getting it just creates this huge diversity in the disease. And people with Parkinson's disease, they might experience like tremors, mainly at rest. They get like kind of this pill rolling tremor of their hands where their hands are just kind of going back, and their fingers are going back and forth over their thumb. Other tremors they'll get other tremors too, where they're just hands, shaking arms, shaking legs. So the biggest side effect from this is just a slowness of movements. So it's called also known as bradykinesia, and it's a slowness of movement. But then you also get like this rigidity, this limb rigidity, which means like you're just they don't stretch very easy. If you were to passively try to stretch them, it'd be a very hard, rigid kind of stretch, and it's not. No matter how hard you push or how fast you push, it's just consistently just very rigid, stiff, and slowed movements. And this also affects their gait and balance. So someone with Parkinson's might just be walking very slowly. They might have difficulty going around turns. They slow around turns. They have more of a shuffling type of gait or walk. And the cause remains largely unknown. They don't really know why it happens. Although there is no cure, there are a variety of treatments and medications that have been known to help significantly. So also surgeries, they can implant brain stimulators right into the patient's brain to help with the movement. So it's just taking a small signal and then exploding it through these stimulation devices. So. All right, so while Parkinson itself is not fatal, the disease's complications can be very serious. So the Centers for Disease and Control and Prevention have rated the complications from Parkinson's as the 14th cause of death in the United States. So the actual disease itself is not fatal, but the complications of the disease can be. Ooh, sorry about that, guys. So next we're going to be talking about just the pediatrics. Some of these will, of course, autism, spina bifida, cerebral palsy. We're definitely seeing adults with these conditions too. It's just the majority of them tend to be our pediatric patients. And since they are mainly birth defects, we're also talking about them in the pediatric part of this. So we're talking about cerebral palsy, and cerebral palsy is like a blanket term that just describes a vast amount of different disabilities, and typically they'll give even an intellectual disability or somebody with like another chromosomal type of disability, a cerebral palsy diagnosis, because of the weight that it carries with it. So these patients that get a diagnosis like cerebral palsy are going to get a lot more open access to durable medical equipment and different standards and gait trainers than somebody with trisomy would. So, or like a chromosomal abnormality would. So that's why it's such a blanketed statement like cerebral palsy. It's going to be kind of hard to encompass in everything. But we'll talk a little bit about what general cerebral palsy is, just to get you guys kind of up to speed with it. So again, it's also known as, cerebral palsy is also known as CP, and it's described by a loss or impairment of motor function. So cerebral palsy is actually caused by brain damage. So the brain damage is caused by brain injury or abnormal development of the brain that occurs while a child's brain is still being developed, like before they've even been born, or sometimes during birth or immediately after birth. Let's say a baby is, heaven forbid, is dropped right after birth. Just impact from the drop or some really low oxygen sats before medical intervention has occurred, can result in cerebral palsy. So cerebral palsy also affects the body, the muscle control, the muscle coordination, the muscle tone, reflexes, posture, balance. It can also impact the fine motor skills as well as the gross motor skills and or motor functioning. So someone with cerebral palsy could be on one end of the spectrum, very uninvolved. Maybe they just have a left foot that looks a little bit different when they're walking, but everything else works completely fine, to somebody else that might be just really involved cerebral palsy patient and doesn't even have the ability to communicate. So you get really two ends of the spectrum with this disability. So next we'll talk about spina bifida. Again, you have many adults with spina bifida, but since it occurs at development of like before birth, prior to birth, baby development, it's so we're going to talk about spina bifida is a part of a group of birth defects called neural tube defects. The neural tube is the embryonic structure that eventually develops into the baby's brain. So this, before the baby actually has a brain, it's just these neural tubes that are being developed. And this and the spinal cord is also considered part of that neural tube, as well as the tissue that encloses them. So normally the neural tube forms in pregnancy and it closes by the 28th day after conception. In babies with spina bifida, a portion of that neural tube fails to develop or closes improperly, and that causes the defects in the spinal cord and the bones around the spine. So the spina bifida occurs in a couple different forms and severities. So you might have one form where the patient presents, again, kind of like non-remarkable. There's no real problem with the patient. So they might have a little scar on their tailbone or something like that. But aside from that, they walk fine, they talk fine, they move fine, they feel fine. They're just pretty much unremarkable. Then you might have someone with meningeal that's like much more involved, that does not have the ability to walk because the cord was exposed and damaged, and now they don't have feeling or motor output in their feet. So again, we treat many different types of spina bifida. There's the ones that come in that just have some balance deficits but can walk and talk and move just fine. And then we've had other ones that are really high spina bifida patients. In other words, the place where the neural tube didn't form and close is very high on the spinal cord, and the patients globally involved. They are intellectually involved as well as physically involved. But your typical spina bifida patient that closes lower down the spinal cord will be cognitively pretty much intact, and it'll just be a motor problem. So the other thing that we treat a lot is autism. And autism or autism spectrum disorder refers to a range of conditions characterized by challenges with social skills, repetitive behaviors, speech and nonverbal communication, as well as like unique strengths and differences. So we know now that there is not just one type of autism, but like many different types of autism, and we're learning more as time goes on. So it's caused from combinations of genetic and environmental influences, And the term spectrum reflects the wide variation in challenges and strengths that are possessed by each person with autism. So they could be anywhere on that spectrum. It's, like I said before, it's not just characterized as, one type of autism, but now there's like a spectrum of autism that it's like, just like the spina bifida, the cerebral palsy patients, there's so many different forms and so many different presentations. So autism's most earliest or most obvious signs tend to appear between 2 and 3 years of age. So in some cases, it can be diagnosed as early as 18 months. Some developmental delays associated with autism can be identified and addressed even earlier. So Autism Speaks is an awesome organization that has tons of information that you can search the web for to learn even more about it. But this is something that we treat. We primarily treat it with occupational therapy, though. So, the other thing that we didn't really talk about is spinal cord injuries. So it's actually something I forgot to throw up here, but we will talk about it very quickly. And a spinal cord injury occurs when a person is injured for some reason at the spinal cord. So they could be hit in the cord and maybe the space between the vertebrae shift, and it creates like a stretch or a contusion on the spinal cord or a bruise on the spinal cord. And basically your brain relays information through your spinal cord, and then it goes out into your out through peripheral nerves that then go into muscles and then make your muscles do things. So if the signal is going from your brain and it's traveling down the spinal cord, and then it hits a bruise on the spinal cord, then the information gets distorted. So maybe some of the information is going through down to the muscle, but instead of telling the muscle to tighten or not tighten or tighten slowly or contract slowly, now it's just constantly on tight. And you're just going to get this like abnormal amount of tone going down to the leg that says it's just always going to be on. There's never off. Even if the brain is telling it to go off, that information is not being relayed properly and it's going down to the muscle and it's just saying fire, fire, fire. So you'll get an abnormal amount of tone. So even somebody with a spinal cord injury can still have an enormous amount of tone in their legs. And we can use that tone to help them stand and utilize it to do good things. Now, we'd like to see tone, like meaning there's some kind of muscle movement there, even if it's not what the patient wants, over just a flaccid muscle, one that has absolutely no tone. So that would be a complete spinal cord injury. Let's say, heaven forbid, John was, chopping wood and he went to put the axe back and the head of the axe flew off and it hit his friend Pete in the back and it severed his spinal cord. That is a complete spinal cord injury. There's no chance of anything going through the point of impact in that spinal cord where the injury occurred. So an incomplete spinal cord injury would be kind of what I was talking about before, that bruise on the spinal cord. The patient falls out of bed and lands on their neck and gets bruised on the spinal cord at level C4, C5, very high on the neck, and is able to somewhat recover from it with slightly abnormal gait just because the bruise was so small. So even though they have a very high spinal cord injury, and Pete, who got the axe through the back and severed his spinal cord really low, the other person that fell out of bed might have a better use of their limbs than Pete would, and might have better outcomes than Pete will. So maybe they could use their hands and still walk, whereas Pete, lost all function underneath of his back and can't. So again, spinal cord injuries are just like anything else in the medical field. You have this spectrum, and you have some people that are able to walk, talk, and breathe, and then you have other people that have very high complete spinal cord injuries that can't even breathe for themselves because just the level of the severity of the injury. If it happens very high, then it's gonna then the higher it goes, the worse it is. So if it's a very high level of impact, meaning like your neck, then it's going to be a lot worse. If it's lower, kind of like at the very end of your back, your sacrum, then it could be a little bit, better. So, but that is it. We have made it through the training, and those are the specialties. Those are the disabilities that we specialize in. And if you guys have any questions or concerns about these disabilities, please feel free to reach out to your manager, your supervisor, your colleagues, and talk more about them. But for the most part, hopefully this has educated you a little bit as to the types of services that we offer, the disabilities that we specialize in, and kind of putting the two together and figuring out what physical therapy would do for that disability or what occupational therapy would do for that disability. So if you guys have any questions, please feel free to reach out. Thank you.